Welcome to the deep dive. Our mission today is arguably the most critical foundation in all of medical surgical nursing, mastering expert respiratory assessment.
Absolutely.
We are taking a comprehensive shortcut through a massive foundational chapter, extracting the anatomy, the physiology, the assessment techniques, and, all the complex diagnostic tools you need to recognize and, more importantly, prevent clinical deterioration.
That's so right. I mean, respiratory compromise is the fastest route to failure in any patient, whether they're post-op, elderly, or managing a chronic disease. This deep dive is explicitly structured to give you, the learner, the foundational knowledge you need to identify those subtle changes and intervene effectively. Understanding this material, it really moves you from being a student to being a truly expert bedside clinician.
Okay, let's unpack this, and I think we have to start with the fundamental vocabulary. In respiratory care, there are three primary functions that just govern everything. So let's clearly define ventilation, diffusion, and perfusion. They sound similar, but they describe very distinct actions.
They really do. Ventilation is purely mechanical. It's the movement of air, just the physical work of breathing, moving gas in and out of the airways and the alveoli.
Just in and out.
Just in and out. Then you have diffusion. That's the physical process of gas exchange itself, where oxygen and carbon dioxide move across that air-blood barrier in the alveoli. It's all based on concentration gradients.
So you're literally trading one gas for the other.
You're trading, exactly. And finally, perfusion, or pulmonary perfusion, that's the cardiovascular component. It's the blood flow through the pulmonary circulation, bringing deoxygenated blood to the lungs and carrying that fresh oxygenated blood away.
And all three have to be perfectly synchronized.
Perfectly. If one fails, they all fail.
And when they aren't synchronized, well, the patient exhibits symptoms that are really the language of respiratory distress.
Yes.
Let's define four critical clinical terms that get used interchangeably all the time, starting with the two feelings: dyspnea and apnea.
Okay, so dyspnea is subjective. It's that uncomfortable sensation of breathing, the patient's internal experience of shortness of breath. It's a critical assessment point because it is entirely what the patient tells you.
Right. It's a symptom, not a sign.
Precisely. Whereas apnea is an objective sign. It's the complete cessation of breathing, even if it's just temporary.
No, the gas issues. We have to nail the difference between hypoxemia and hypoxia.
Oh, this is so crucial. Hypoxemia is an objective measurement. It's a decrease in the partial pressure of oxygen, the PA2, in the arterial blood. It literally means your blood gas is low.
So it's a lab value.
It's a lab value. Hypoxia, however, describes the consequence of that. It's the actual decrease in oxygen supply at the cellular and tissue level. So hypoxemia causes hypoxia, but you could have localized hypoxia, like in a severely ischemic limb, without having systemic hypoxemia.
I see.
The nursing focus is always, always to prevent tissue hypoxia.
Okay, let's define the last set of vocabulary terms that relate directly to the physical exam. We need to understand compliance, the lung's physical property, and then the three classic abnormal sounds: crackles, raunchy, and the one that's an immediate emergency, stridor.
Right. So compliance measures the force required to expand the lungs and the thorax. It's essentially how elastic and pliable they are. High compliance means they stretch easily. Low compliance means they are stiff and require a massive effort to inflate.
And the sounds. Let's start with crackles.
Crackles are non-musical, discontinuous. Think of them as popping or clicking sounds usually heard on inspiration. They're caused by the sudden, delayed reopening of previously collapsed airways.
So you're hearing that pop open?
Exactly. And they're often associated with fluid or inflammation, like in heart failure or pneumonia. Then you have raunchy, which are lower-pitched, continuous snoring or rumbling sounds.
Okay.
These are often associated with larger airway obstructions from thick secretions, and they commonly change or even clear after a forceful cough.
And the sound that immediately triggers emergent action, stridor.
Yes. Stridor is distinct because it originates high up in the airway. You hear it best over the neck or trachea, not necessarily deep in the lung fields.
So it's not a lung sound, it's an airway sound.
It's an airway sound. It is a continuous, high-pitched musical sound, usually on inspiration, and it signals severe, immediate upper airway obstruction. Think of foreign body, severe inflammation, anaphylaxis. If you hear stridor, you are escalating care right now.
That intensive vocabulary groundwork, I think, allows us to move into part one, the respiratory blueprint anatomy and core function. We start with the structural tour, specifically the upper respiratory tract.
Yeah.
This is the body's sophisticated air preparation system.
It really is. The upper tract's job is simple but vital: warming, filtering, and humidifying the inspired air. It all starts with the nose. The air travels past the turbinates or conchae, which increase the surface area and create turbulence.
And why is that turbulence important?
It ensures the air maximizes contact with the highly vascular ciliated mucous membrane. This allows all that dust and all those organisms to be trapped and filtered before the air goes any further down.
And just behind the nose are the paranasal sinuses. The list has 4 pairs: frontal, ethmoid, sphenoid, and maxillary.
Right, and clinically, their function as resonating chambers for speech really takes a backseat to their role as common infection sites.
Oh, okay.
They're just bony cavities lined with mucosa that connect to and drain into the nasal cavity. When that drainage gets blocked, that's when you get sinus pressure and infection.
Following the air path, we move through the pharynx, which connects the oral and nasal cavities, past the tonsils and adenoids.
The tonsils and adenoids are the key lymphoid guards. They contain tissue that's crucial for the immune response, providing a defense link against inhaled or ingested organisms. They are strategically positioned to catch anything coming into the body through the mouth or nose.
Like little gatekeepers.
Exactly.
And then we reach the larynx, which is beautifully described as the watchdog of the lungs. Why that specific title?
Because it guards the lower airway. I mean, yes, it facilitates speech, it houses the vocal cords, but its primary function is protection. It ensures food and liquids do not enter the trachea.
So what are the key protective structures in the larynx?
Well, the epiglottis is the big one. It's the valve flap that swings down to cover the laryngeal opening during swallowing.
I see.
Below that, the glottis is the actual opening between the vocal cords. The largest cartilage is the thyroid cartilage. That's the Adam's apple. But maybe most important for structure is the cricoid cartilage.
Why that one?
It's the only complete cartilaginous ring in the entire airway system. It provides a stable structural anchor for everything else.
And from the larynx, we descend into the trachea, supported by its signature C-shaped rings.
Right. The C-shaped cartilage rings are incomplete on the back, where the trachea meets the esophagus. But those rings are what prevent the trachea from collapsing, maintaining a patent airway all the way down to the main stem bronchi.
Okay, let's switch gears now to the lower respiratory tract, the lungs. They are elastic structures housed within the airtight thoracic cage. Tell us about the lobar division.
Structurally, the right lung is the powerhouse with 3 lobes, upper, middle, lower. The left lung has to accommodate the heart, so it only has 2 lobes, upper and lower.
And that's critical knowledge for auscultation, right? For localizing pathology.
Absolutely. You have to know where you're listening.
Surrounding these lungs, facilitating their effortless movement, is the pleura.
Yes, you have the visceral pleura, which wraps tightly around the lung surface itself, and the parietal pleura, which lines the inside of the thoracic cavity.
And between them.
Between them is a tiny amount of pleural fluid. Its purpose is to act like a frictionless lubricant, allowing the 2 layers to just slide smoothly against each other during breathing. This ensures the lungs inflate and deflate without any friction or pain.
And air continues its journey down the bronchial tree.
Right. The path is trachea to main stem bronchi, then lobar, segmental, and subsegmental bronchi, and it finally ends in the bronchioles.
And these are unique, right?
They are. These smallest conducting airways are unique because they lack cartilage. Their openness, their patency, relies solely on the surrounding elastic recoil and alveolar pressure. If the elasticity of the lung structure is compromised, these bronchioles are the first to collapse, and that leads to air trapping.
And we have to account for the air that is inhaled never participates in exchange. The physiologic dead space.
Right, that's the volume of air, roughly 150 millirel, that just stays in the conducting airways, trachea, large bronchioles. It's physically there, but it never reaches the gas exchange surface.
So what's the clinical significance of that?
Well, when a patient takes very shallow breaths, they are often only ventilating their dead space. That's a key sign of impending respiratory failure. They're moving air, but it's not doing anything.
Okay, now let's explore the alveoli, the primary site of gas exchange. The microarchitecture is, well, it's genius, involving 3 cell types.
It is remarkably efficient. Type I cells cover about 95% of the surface area and form that incredibly thin air-blood barrier where diffusion occurs. Then you have type II cells.
Functional cells.
Exactly. They are the crucial functional cells. They produce the type I cells, and most importantly, they produce surfactant.
Surfactant is non-negotiable for normal lung function. What is its main job?
It's a lipoprotein that dramatically reduces the surface tension inside the alveoli. Without it, the small alveoli would just collapse completely during expiration, making the next inspiration require huge amount of effort.
And we see that clinically, right?
Oh, yeah. In premature babies or patients with acute respiratory distress syndrome, ARDS, surfactant deficiency, or inactivation is the root cause of those stiff, non-compliant lungs.
And the third cell type, the alveolar macrophages.
These are the phagocytic defense cells. They're like little security guards patrolling the alveoli, ingesting foreign matter that the cilia failed to filter out, ensuring that delicate gas exchange surface remains clean and clear.
So moving to core functions, we established oxygen transport, getting O2 from the alveoli to the blood, relies on the process of respiration.
Respiration is governed by simple physics. Oxygen diffuses from the area of high concentration, the alveoli, into the blood, which has a low concentration. And CO2, produced by metabolism, diffuses from the blood, high concentration, into the alveoli, low concentration. This gradient is what drives everything.
And finally, a reminder on perfusion and the concept of shunted blood.
Right. Pulmonary perfusion is the blood flow. Normally, about 2% of the blood pumped by the right ventricle bypasses the alveolar capillaries entirely and drains directly into the left heart. This is a normal physiological shunt.
But it can become pathological.
It can. If a state like pneumonia increases that shunted percentage significantly, hypoxia results because that blood just never gets oxygenated.
Part 2 is where the physics and chemistry really merge, the engine room mechanics of ventilation and gas transport. Let's dive deeper into the physical process of breathing.
Okay, so we're looking at energy expenditure here. Inspiration is active. It requires energy. The diaphragm contracts and flattens, the chest cavity expands, and this drop in pressure below atmospheric pressure is what draws air in.
And expiration.
Expiration is normally passive. It's just the simple relaxation of the diaphragm, and the elastic recoil of the lungs forces the air out.
So the moment expiration becomes an active, energy-consuming process, like when you see a patient using accessory muscles. That's a huge red flag that something is wrong.
A huge red flag.
And that usually reflects significantly increased airway resistance.
Exactly. Airway resistance is determined by the radius of the bronchi. If that radius shrinks, resistance rises exponentially, demanding increased work of breathing. We really need to detail the causes of this increased resistance.
Okay, let's start with the most common, like asthma and chronic bronchitis.
In asthma, you have contraction of the bronchial smooth muscle, leading to acute narrowing. In chronic bronchitis, you have a thickening of the bronchial mucosa and excessive mucus production, which physically narrows the lumen. Both require greater pressure to push air through.
But the cause in emphysema is less intuitive. How does a loss of elasticity in emphysema increase resistance?
This is a critical insight. Healthy lungs have this elastic connective tissue that surrounds the small airways. During expiration, this tissue creates what we call radial traction, pulling the airways open.
Okay.
In emphysema, that elasticity is destroyed. So during expiration, when the pressure differential is pushing air out, those unsupported small airways collapse prematurely, trapping air and dramatically increasing the perceived resistance to exhaling.
That structural failure makes it so clear why it's so hard for COP patients to get air out. Now let's return to compliance, which measures elasticity. You mentioned two dangerous extremes.
Right. The ideal compliance allows for easy expansion. But increased compliance means the lung has lost its elastic quality. It stretches easily, but has no snapback.
Like an old rubber band.
Exactly. Think of a bag getting hyperinflated. This is classic for long-standing emphysema. The patient can breathe in easily, but the recoil for expiration is just gone.
And conversely, decreased compliance, the stiff lung.
Decreased compliance means the lungs or the thorax are stiff and difficult to inflate. You see this in conditions like severe obesity, massive pleural effusion, ARDS, or pulmonary fibrosis. The patient experiences a dramatic increase in the work of breathing, and that leads to rapid fatigue and potential respiratory muscle failure.
Let's talk about measuring the air itself, lung volumes and capacities. We need to differentiate volumes from capacities and identify the most important measurements.
Okay, so tidal volume, TV, that's about 500 millil, is the air moved with a normal resting breath. Residual volume, RV, is the air remaining after a maximal forced exhalation. Clinically, an increased RV is the classic indicator of air trapping and hyperinflation in obstructive diseases like COPD.
And the capacities, which are combinations of volumes.
The most critical combination is vital capacity, VC. That's the maximum volume of air you can exhale after a maximal inspiration.
It's a measure of functional capacity.
It is. A significantly decreased VC, like what we see in severe neuromuscular disease like Guillain-Barré or extreme fatigue, is a grave finding. It signals the patient is approaching ventilatory failure. Then total lung capacity, TLC, is just the sum of all four volumes. TLC increases in obstruction because more air is trapped, and it decreases in restriction because the lungs are stiff.
This analysis of physics and volume leads directly to the mechanism of most respiratory failure: ventilation and perfusion, VQ, balance and imbalance.
Right, the VQ ratio is the amount of air, V, that meets the amount of blood, Q. The ideal lung has a 1-to-1 ratio. Any imbalance leads to shunting, which is the primary cause of hypoxia. If VQ fails, O2 saturation falls dramatically.
Let's detail the 3 problem states identified in the source, starting with the low VQ ratio, or shunt.
Okay, think of a shunt as blocked ventilation, but the blood flow is fine. Perfusion exceeds ventilation. The blood arrives at the alveolus, but the air is blocked, maybe by a mucus plug, atelectasis, or the fluid filling of pneumonia.
So the blood just goes right by.
It bypasses gas exchange and returns deoxygenated to the left heart. If this shunting exceeds 20% of pulmonary blood flow, the patient becomes severely hypoxic. And oxygen therapy alone often won't fix a true shunt because the O2 just can't physically reach the blood.
And the opposite is the high VQ ratio, or dead space.
Here, ventilation exceeds perfusion. There's plenty of air, but there's inadequate blood flow to pick up the oxygen. The most classic example is a pulmonary embolus, PE, where a clot physically blocks the blood flow.
Okay.
Other causes could be cardiogenic shock or pulmonary infarction. The alveolus is ventilated, but it's useless. It's just acting as dead space.
And the catastrophic silent unit.
That's where both ventilation and perfusion are absent. The whole area is completely shut down. This happens in severe pneumothorax or end-stage ARDS. It signals widespread, often irreversible pulmonary failure.
Moving to chemistry. Gas exchange and partial pressures. Why is understanding partial pressure so important?
Because gas movement is driven entirely by the pressure exerted by that specific gas. Inhaled air gets diluted really quickly. Water vapor pressure alone exerts 45 millimeter Hg once the air is humidified. Furthermore, as CO2 returns from the blood, it further dilutes the oxygen. This results in the alveolar O2 tension, the PaO2, being about 100 millimeter Hg, which is just enough pressure to push O2 across the membrane and into the blood.
Once in the blood, oxygen transport is governed by its relationship with hemoglobin, HGB.
Right. Most oxygen, 97% of it, is combined with HGB to form oxyhemoglobin, which is what we measure as SO2 or saturation. The remaining tiny portion is just dissolved in plasma, which we measure as PaO2 or partial pressure. The goal is to maximize both.
And the relationship between PO2 and SO2 is beautifully illustrated by the oxyhemoglobin dissociation curve. Why is that S shape so beneficial?
It's pure evolutionary genius. The top, or the plateau of that S-curve, shows that even if the PO2 drops from 100 millimeter Hg down to 70, the HB saturation, the SO2, only drops slightly. It stays in the high 90s.
It's a buffer zone.
It's a buffer zone that protects the patient from immediate tissue hypoxia if they have mild lung disease. The steep part, however, that's the critical zone. Once PO2 drops below 60 millimeter Hg, HGB saturation just plummets, and oxygen is released rapidly to the tissues. Clinically, 90% AO2 roughly correlates to a PO2 of 60. That's the boundary you never want to cross.
And what causes the curve to shift?
The shift describes the strength of the bond between O2 and HGB. A shift to the right means the bond is weaker. HGB picks up less O2 in the lungs, but critically it releases more O2 to the starving tissues.
When would that happen?
It happens when the body is demanding more oxygen during exercise, a fever, or acidosis, where you have increased CO2 and H+ concentration.
In the defensive maneuver, the shift to the left.
That's a stronger bond. More O2 is picked up in the lungs, but it's released less readily to the tissues. This happens when those factors decrease hypothermia or alkalosis. While this is protective in the lungs, preventing HGB from giving up its O2 load too soon, it can actually impair tissue oxygenation if the alkalosis is severe.
And to wrap up the functional mechanics, we have to acknowledge that oxygen delivery is ultimately constrained by cardiac output.
Oh, absolutely. Oxygen delivery is the product of content and flow. You can have perfect lungs and 100% AO2, but if the heart is failing and cardiac output drops, the total amount of oxygen circulating to the tissues per minute will be inadequate, and that leads to shock and death.
Finally, let's touch on the neurologic and age-related control of respiration. Where is the rhythm set?
The involuntary rhythm is set in the medulla and pons of the brainstem. They house the inspiratory and expiratory centers, and they constantly modulate rate and depth based on signals from chemoreceptors.
Which chemoreceptors detect the primary drive to breathe?
The central chemoreceptors, located in the medulla, are the most sensitive. They respond primarily to changes in pH in the cerebrospinal fluid, which is indirectly driven by the PaSO2 in the arterial blood. If CO2 rises, pH drops, and the medulla signals an increase in ventilation.
And the peripheral chemoreceptors.
They're our backup system. They live in the aortic arch and carotid arteries. They respond first to significant drops in PO2. Once PO2 drops below 70, they activate. They also contribute to responding to major pH changes.
Well, the decline with age, gerontologic considerations. This has significant implications for our high-risk patients.
It does. Aging starts the decline pretty early, usually post-25 years. Structurally, the chest wall becomes more rigid due to calcification of the intercostal cartilage. The alveoli lose elasticity, and the surface area available for gas exchange decreases.
And functionally, what does that result in?
Functionally, it results in two key problems: decreased vital capacity and expiratory flow rates, and increased physiological dead space.
So what does that mean clinically for the elderly patient?
It means they have dramatically reduced respiratory reserve. They can handle daily activities fine, but their tolerance for prolonged activity, illness, or major surgery is very low. Their PO2 is naturally lower, and they are much less able to rapidly cough or take a deep breath, making them highly susceptible to complications like atelectasis or pneumonia.
That structural and functional map really sets the stage for part 3, the assessment toolkit history and physical examination. We're moving from theoretical science to clinical detection. We have to master the symptoms of respiratory dysfunction.
Right, and the history is where we quantify the patient's subjective experience. We need to fully characterize the onset, duration, severity, and the functional impact of their symptoms.
Let's start again with dyspnea. That's subjective discomfort. When is sudden onset the most alarming?
Sudden onset dyspnea in a previously healthy person demands immediate investigation. You have to think pulmonary embolism, PE, pneumothorax, or acute decompensation. Chronic dyspnea, on the other hand, is more typical of COPD, interstitial lung disease, or progressive heart failure. A crucial nursing skill here is to quantify the distress using a standard scale, often 0 to 10, to measure how bad the shortness of breath is and how many activities it prevents them from doing.
And we must ask specifically about orthopnea.
Oh yes, orthopnea is dyspnea that occurs when the patient lies flat, and it's classically relieved when they sit or stand upright. This is a hallmark finding in patients with congestive heart failure because of the redistribution of fluid into the lungs when they're supine.
Next, the protective reflex. The cough. What diagnostic clues does its timing provide?
Timing is everything. A cough that is worse at night might suggest heart failure or asthma. A cough that is prominent in the morning with excessive sputum often points toward chronic bronchitis, where secretions build up overnight.
What if it worsens when they lie down?
If the cough worsens when lying supine, we might suspect chronic rhinitis or postnasal drip.
What about the character of the cough?
A dry, hacking, irritative cough is often non-productive. It could be from an upper airway infection or, importantly, a side effect of ACE inhibitor medication used for hypertension or heart failure.
Okay.
A high-pitched or brassy cough may signal a tracheal lesion. And we have to remember the associated risks. A violent, persistent cough can actually cause syncope or rib fractures.
Sputum production gives us immediate visual diagnostic clues. What colors are most alarming?
We look for volume, consistency, and color. Purulent sputum, thick, yellow, green, or rust-colored, suggests a significant bacterial infection. Thin, mucoid sputum is more typical of viral bronchitis.
But there are a few that are immediate red flags.
Yes. Pink-tinged mucoid sputum often raises concern for a lung tumor. And most urgently, profuse, frothy, pink sputum is a classic non-negotiable sign of acute pulmonary edema, signaling fluid is rapidly backing up into the alveoli from the heart.
Let's talk about chest pain. The challenge here is differentiating pulmonary pain from cardiac or GI pain.
Right. Pulmonary pain, particularly pleuritic pain, is typically sharp, stabbing, and intermittent, and it's usually made worse by a deep inspiration, coughing, or movement.
And it's localized.
It's felt right over the site of the inflammation. And here's the crucial nursing clue. Pleuritic pain is often relieved when the patient lies on the affected side. This position acts to splint the chest wall, minimizing movement and friction. Cardiac pain, of course, is typically crushing and non-positional.
The last two key symptoms, wheezing and hemoptysis.
Wheezing is that continuous, high-pitched musical sound indicating a narrowed airway diameter, often throughout the chest. Hemoptysis, the expectoration of blood, must always be taken seriously and investigated.
So when a patient coughs up blood, the nurse's immediate priority is determining the source, lung or stomach. How do we differentiate?
Blood from the lung, or hemoptysis, is typically bright red. It's frothy because it mixes with air, and it has an alkaline pH greater than 7. The patient might even report a bubbling or tickling sensation.
And from the stomach.
Blood from the stomach, hematemesis, is darker. It often looks like coffee grounds, it's mixed with food particles, and it's acidic with a pH less than 7. This distinction guides immediate intervention.
We move now to the past, social and family history, focusing intensely on risk factors.
The number one risk factor remains tobacco. We quantify this using pack years. Packs per day multiplied by the years smoked. We have to determine current use, cessation time, and exposure to other environmental risks.
The source highlights the emerging risk of ENDS, or e-cigarettes. What is the specific danger here that nurses need to be aware of?
E-cigarettes contain toxic substances, notably acrolein, which is a known lung irritant and a component of weed killer.
Wow.
Yeah, their use is linked to an increased risk of cough, wheeze, and asthma exacerbations, particularly in younger populations. We can no longer treat e-cigarette use as a benign habit.
And the role of genetics in nursing practice.
Many respiratory conditions are genetically influenced: asthma, COPD, cystic fibrosis, and alpha-1 antitrypsin deficiency. For example, alpha-1 antitrypsin deficiency often leads to early-onset emphysema. So the nursing assessment has to include a thorough 3-generation history to identify any familial patterns of early chronic disease.
We must also acknowledge the role of health disparities in pulmonary care.
Disparities are rooted in socioeconomic and systemic factors. We see higher smoking rates and lower access to care in rural areas. Lower-income communities often experience worse outcomes, like more frequent and severe asthma exacerbations. And studies show African American men face a higher lung cancer risk than Caucasian men, even with comparable smoking histories.
Now, the physical assessment started with inspection. We begin with general appearance, looking for the telltale signs of chronic hypoxia, clubbing of the fingers and cyanosis.
Clubbing is characterized by a spongy nail bed and an increase in the angle between the nail and the cuticle to 180 degrees or more. It signifies long-standing chronic hypoxic conditions, often associated with chronic lung infections or malignancies.
And while it's striking, cyanosis is a notoriously poor and late indicator of hypoxia. Why is it so unreliable?
Because it requires at least 5 GDL of unoxygenated hemoglobin to be visible. So if the patient is anemic low overall hemoglobin, they may be profoundly hypoxic, but never meet that 5 GDL threshold, so they never look blue.
And the opposite can be true, too.
Right. A patient with polycythemia, which is excessive red blood cells, might appear cyanotic even if their PaO2 is adequate.
We distinguish central cyanosis from peripheral cyanosis.
Central cyanosis, which you see in the mucous membranes like the lips and tongue, indicates a systemic issue, a low PaO2. Peripheral cyanosis, seen in the extremities, often results from local vasoconstriction or poor blood flow due to cold or shock, not necessarily a systemic oxygenation problem.
After inspecting the upper structures, we assess the trachea.
The trachea should be midline. We palpate it just above the sternal notch. Tracheal deviation is a crucial finding because it signals a major shift in intrathoracic pressure. It can be pushed away by a large tension pneumothorax or a massive pleural effusion, or it can be pulled toward the affected side by massive atelectasis or fibrosis.
We inspect the chest configuration. The normal AP collateral diameter ratio is 1.2.
When that ratio changes, it suggests chronic disease. The classic sign of chronic obstructive disease is the barrel chest, where the AP diameter increases to nearly 1:1 due to chronic lung hyperinflation and air trapping.
And the other deformities we need to recognize.
Funnel chest, or pectus excavatum, is an inward depression of the sternum. Pigeon chest, pectus carinatum, is an outward protrusion. And kyphoscoliosis is a severe lateral and posterior spinal curvature that physically restricts the expansion of the thoracic cage, fundamentally limiting lung capacity.
Observing breathing patterns is fundamental. We look for eupnea, which is normal, and then we identify the abnormal patterns.
Right. Bradypnea is slow, less than 10 breaths per minute, and it suggests depression of the respiratory center, maybe from an opioid overdose or brain injury. Tachypnea is rapid and shallow, more than 24 breaths per minute, a common response to fever, pain, or pulmonary edema. Hyperventilation is increased rate and depth, which blows off CO2, and when it's associated with severe acidosis, it's called Kussmaul's respiration, which is classic in DKA.
Okay, let's nail down the difference between the two irregular patterns, Cheyne-Stokes and Biat's.
Cheyne-Stokes is a regular cyclical pattern. The rate and depth wax and wane. They increase, then decrease until a period of apnea occurs. It's often associated with severe heart failure or damage to the respiratory centers.
In Biat's.
Biot's respiration is much more irregular. You have periods of normal depth breathing followed by sudden, unpredictable periods of apnea. Biot signals severe respiratory depression and brain injury, typically at the medulla level.
And finally, identifying obstructive breathing.
This pattern is characterized by a significantly prolonged expiratory phase. You can see the visible struggle to push air out, which is classic in asthma and COPD. And you always have to inspect for the use of accessory muscles, the scalene, trapezius, and sternocleidomastoid.
Which indicates what?
It indicates that the diaphragm and intercostals alone cannot meet the respiratory demand. This is a sign of respiratory fatigue.
Next, we move to palpation and percussion. Palpation starts with assessing respiratory excursion.
We check the range and symmetry of chest expansion. Asymmetric excursion is highly significant. It suggests that one side is restricted, maybe due to splinting from a rib fracture, a unilateral bronchial obstruction, or a pneumothorax on one side.
Then the vocal vibration, tactile fremitus.
Right. We ask the patient to repeat a phrase like 99 while we palpate. Sound travels better through solid tissue than through air. Therefore, fremitus is increased over areas of consolidation, where air-filled lung tissue has been replaced by solid tissue, like in pneumonia.
And decreased.
Conversely, fremitus is decreased or absent when air or fluid separates the lung from the chest wall, like in emphysema, where there's too much air, or a pleural effusion, which creates a fluid buffer.
Moving to percussion. We use this technique to determine if the underlying tissue contains air, fluid, or is solid. What are the key sounds?
The expected sound over healthy lung tissue is resonance, a low-pitched hollow sound. If we percuss and hear dullness, that means air has been replaced by fluid or solid tissue, like over the liver or in pneumonia. If we hear flatness, it's a very dense sound, like over the thigh or a massive pleural effusion.
And the sounds of excessive air.
Hyperresonance is an abnormally loud, lower-pitched sound. It signals increased air or air trapping, and it's classic in emphysema or pneumothorax. Tympany is a musical, drum-like sound, usually heard over the stomach or a large, simple pneumothorax.
We can also use percussion to measure diaphragmatic excursion.
Yes, this is a direct measure of diaphragmatic movement. We percuss to find the point where lung resonance changes to dullness, which is the diaphragm, during maximal inspiration and again during full expiration. The normal range is 5 to 7 centimeters. A decreased excursion suggests restricted movement due to conditions like atelectasis, severe effusion, or paralysis.
We conclude the physical exam with auscultation. First, the normal breath sounds.
We listen for vesicular sounds, soft, low-pitched, heard over the entire lung field where inspiration is longer than expiration. Bronchoscopy sounds are intermediate, and bronchial or tubular sounds are loud and high-pitched, with expiration longer than inspiration.
And those should only be heard in one place.
Exactly. Bronchial sounds should only be heard over the trachea and manubrium.
So the critical nursing takeaway, if we hear loud, high-pitched bronchial sounds in the periphery, what does that signify?
It means consolidation. Those high-frequency sounds are typically filtered out by healthy lung tissue, but if the tissue is solidified by pneumonia or a tumor, it conducts those sounds clearly to the chest wall. That is an immediate sign of pathology.
Next, the adventitious sounds, the abnormal sounds.
Yeah.
You mentioned the distinction between discontinuous, like crackles, and continuous, like wheezes and raunchy.
Let's detail the crackles. Fine crackles are high-pitched, non-musical, they sound like hair rubbing together, and are typically heard mid to late inspiration. They suggest restrictive diseases like pulmonary fibrosis or CHF.
And coarse crackles.
Coarse crackles are louder, lower-pitched, moist sounds, often heard early in inspiration or expiration, and are associated with large airway secretions or heart failure.
And the continuous sounds.
Wheezes are continuous, musical, high-pitched sounds produced by air rushing through narrowed airways. They're often heard on expiration and are the classic finding in asthma. Raunchy are lower-pitched rumbling sounds caused by secretions in the larger airways, and a key clue is that they often change or clear after the patient coughs.
We return again to the emergent sound, stridor.
Right. Stridor is a continuous, high-pitched musical sound over the neck. Unlike wheezes, which occur in the lower tract, stridor means the upper airway is narrowed, the larynx or trachea. This is an emergent threat to ventilation and requires immediate attention to secure the airway.
Finally, we assess voice sounds, vocal resonance, if we suspect consolidation.
Right. If the underlying lung tissue is consolidated, the patient's speech sounds become clearer. So we check for bronchophony, where the voice is clearer and louder than normal. We check for egophony, where the patient says E through the stethoscope, but it sounds like a nasal A, and whispered pectoriloquy, where whispered words are heard clearly and loudly.
And all three point to the same thing.
All three indicate high-density tissue underneath the stethoscope.
We move to part 4, measuring and diagnosing respiratory function. Before formal testing, let's discuss assessment in acute critical illness. The nursing priorities change dramatically here.
Oh, absolutely. The priorities shift to maintaining stability. For a critically ill patient, the nurse has to meticulously check ventilator settings and alarms, ensure patient ventilator synchrony, and monitor continuously for acute distress flaring, accessory muscle use, or uncoordinated chest movement.
Positioning is often a life-saving intervention.
It is. Elevating the head of the bed, the Fowler's position, is standard to prevent aspiration and improve lung expansion. But in the most severe cases, like ARDS with refractory hypoxemia, the patient may require prone positioning.
Lying on their stomach.
Lying on their stomach. It often helps redistribute air and blood flow and can significantly improve oxygenation.
Let's emphasize the crucial quality and safety nursing alert regarding relying on visual cues.
This is non-negotiable. You can never rely solely on watching the rate and depth of breathing. A patient may appear to be breathing normally, but if their breaths are shallow, they may only be moving air in and out of their dead space, leading to massive CO2 retention and failure.
So you have to listen.
Always use auscultation, pulse oximetry, and capnography to verify ventilation adequacy.
What are the key bedside monitoring tests used to gauge respiratory effort?
We use bedside spirometry to measure tidal volume, VT, the volume per breath, and crucially, we calculate minute ventilation, which is just TV times the respiratory rate. A low minute ventilation means the patient isn't moving enough air overall, and their PaCO2 will rise.
And the vital warning related to vital capacity, VC.
The source contains a critical alert. If the vital capacity is measured as less than 10 millikilograms of body weight, the patient usually lacks the reserve and muscle strength to sustain spontaneous ventilation and will require mechanical ventilation.
That's a red line.
It's a red line measurement often used for weaning assessments.
We also measure forced expiratory volume in 1 second, FEV1, and inspiratory force.
Right. FEV1 measures airflow obstruction, how much air the patient can exhale in the first second. If the FEV1 FEC percentage is reduced, the patient has obstructive disease. Inspiratory force measures the negative pressure generated by the inspiratory muscles. A negative pressure less than 25 centimeter H2O usually indicates insufficient muscle strength for deep breaths or an effective cough, again signaling the need for ventilatory support.
Moving to diagnostic evaluation, we start with pulmonary function tests, PFTs.
PFTs use the spirometer to provide comprehensive data on volumes and flow rates. They're used for diagnosis, for screening before high-risk surgeries, especially thoracic surgery, and for monitoring response to bronchodilator therapy. But while they're powerful, PFTs measure generalized function. Localized changes might still require imaging.
Blood gas studies are the definitive measure of metabolic and respiratory status.
Yes. Arterial blood gases, ABGs, give us PO2, and the pH bicarb status. Complications of sampling include pain, hematoma, and infection at the puncture site. Venous blood gases, VBGs, offer insight into the balance of oxygen delivery and consumption. The gold standard for this balance is mixed venous oxygen saturation, or SVO2, measured via a pulmonary artery catheter, which tells us exactly how much oxygen the tissues are extracting.
The non-invasive giant is pulse oximetry, SpO2. What are its crucial limitations that nurses often forget?
It is fantastic for monitoring SO2 in real time, but its limitations are huge. It cannot detect hyperoxemia, a dangerously high PO2. It cannot measure PaTO2, meaning the patient could be retaining massive amounts of CO2, hypoventilating, while having an adequate SpO2.
Wow.
And its reliability drops dramatically in low perfusion states like shock or hypothermia, or when interference occurs, like with nail polish or dark skin pigmentation.
To monitor ventilation non-invasively, we use end-tidal carbon dioxide, EtCO2 monitoring, or capnography.
Right. EtCO2 measures the CO2 concentration at the end of exhalation. It's highly valued for two reasons. First, it provides immediate and reliable confirmation of endotracheal tube placement. Second, it's often the earliest indicator of respiratory depression, showing a rise in CO2 long before the SpO2 begins to drop.
You mentioned an alert about false positives with EtCO2.
Yes. If a patient is undergoing bag mask ventilation, or if they've recently ingested a significant amount of sodium bicarbonate, it can temporarily cause a false high reading. But generally, in the intubated patient, a sudden drop in EtCO2 often signals a sudden loss of cardiac output.
Let's discuss cultures and imaging. For cultures, the timing relative to antibiotics is key.
Always. You always collect sputum, throat, or nasal cultures before initiating antibiotic therapy. Otherwise, the results will be skewed. Sputum collection is best done early in the morning. The patient clears their nose and throat, rinses their mouth, and then coughs deeply from the lungs to produce the sample.
Moving to imaging, the humble chest X-ray.
Chest X-rays detect major densities like tumors, fluid accumulation, or consolidated areas. They're usually taken at full inspiration to maximize visualization of the lung fields.
The CT scan offers superior soft tissue distinction. What are the major nursing safety alerts for a contrast CT?
The contrast dye is nephrotoxic. The nurse must verify kidney function BUN and creatinine and assess for allergies to iodine or shellfish. But the most critical safety alert is for patients taking metformin, glucophage.
Right.
It has to be withheld the day of the test and for 48 hours afterward to prevent the risk of developing life-threatening lactic acidosis when combined with the contrast agent.
We use pulmonary angiography CTPA primarily to visualize the pulmonary vasculature, often for ruling out PE. What are the pre- and post-procedure nursing implications?
This is invasive. Pre-procedure, informed consent, NPO status, assessment for allergies, and kidney function. Patients must be warned about the common but alarming warm flushing sensation or chest pain they might feel during the injection.
And after.
Post-procedure. Meticulous monitoring of the injection site for bleeding and hematoma formation, immobilization of the affected extremity for several hours, and frequent neurovascular checks.
MRI uses magnetism, not radiation. What are the absolute contraindications?
The presence of any implanted metal devices that are incompatible, aneurysm clips, pacemakers, certain cochlear implants, is an absolute contraindication because of the magnetic field. Nurses have to ensure the patient removes all metal, including foil-backed medication patches. Patients also need to be warned about the extreme noise and offered earplugs.
Finally, lung scans like the VQ scan and the PET scan.
The VQ scan compares the ventilation component to the perfusion component, specifically looking for mismatches that are highly indicative of a pulmonary embolism. The PET scan evaluates malignancy by measuring the metabolic activity of tissue. For PET scans, patients must be NPO for 4 hours and must avoid caffeine, alcohol, and tobacco for 24 hours prior, as these can alter metabolic activity and cause false readings.
We wrap up with the highly invasive endoscopic and biopsy procedures, starting with bronchoscopy.
Bronchoscopy uses a scope to directly inspect the larynx, trachea, and bronchi. It's used for diagnosis visualization, tissue samples, and for therapy, like foreign body removal or controlling bleeding.
The nursing care here is extremely high risk due to the risk of aspiration.
It is paramount. The patient must be NPO for 4 to 8 hours pre-procedure. Preoperative meds include atropine to dry secretions and a sedative to suppress the gag reflex.
And there's a big safety alert here.
A major one. Sedation or anesthesia may precipitate respiratory arrest in patients with pre-existing respiratory insufficiency. Post-procedure, the patient has to remain strictly NPO until the cough and gag reflexes return completely. The nurse monitors continuously for hypoxia, bleeding, and signs of laryngeal edema or respiratory distress.
What about examining the pleural cavity thoracoscopy via TS?
This is a surgical procedure to examine the pleural space, often used for biopsy or treating a spontaneous pneumothorax. Post-procedure monitoring focuses on pain and, more importantly, checking the chest tube output and ensuring adequate suction and patency, as well as monitoring for recurrence of a pneumothorax.
And the simple aspiration of fluid or air.
Thoracentesis.
This is done at the bedside under local anesthesia, aspirating fluid or air from the pleural space for analysis or for relief of pressure.
Finally, any type of lung biopsy, transbronchial or percutaneous needle. What are the 3 primary complications the nurse must watch for and educate the patient about?
The 3 major risks for any lung biopsy are pneumothorax, pulmonary hemorrhage, and empyema, which is an infection. The essential post-procedure instruction for the patient and their family is that they must immediately report pain, visible bleeding, or, most critically, any shortness of breath.
Because that's the classic sign.
It's a classic sign of a developing pneumothorax.
As we synthesize this massive deep dive, let's condense this foundational knowledge into 4 essential pillars that every learner must carry into practice. Okay, first, the structure and function. Air moves effectively only if the structures are patent and the alveoli are stabilized by surfactant. Simple as that. Second, the crucial physics, the VQ balance. You have to recognize that VQ mismatch, particularly shunting, is the mechanism of hypoxia, and not all hypoxia is treatable by oxygen alone.
Okay, third pillar.
Third, mastering the meticulous physical assessment. Knowing that increased fremitus and bronchial sounds mean consolidation, whereas hyperresonance and decreased breath sounds mean air trapping or an effusion, you're painting a clinical picture with sound and touch.
And the fourth pillar is the diagnostic vigilance, understanding the risks and crucial nursing implications for every single procedure.
That's right. That means knowing to prioritize MPO status before procedures that enter the airway, like a bronchoscopy, holding specific medications before contrast studies, like metformin for CT, and religiously monitoring for pneumothorax after any invasive lung procedure like a biopsy or thoracentesis.
So, given the complexity of EQ mismatch and the unreliability of cyanosis as a late sign, here is the provocative thought for you, the learner, to consider. How should nurses prioritize using the non-invasive tools we discussed, specifically SpO2 and EtCO2, to detect subtle deterioration, especially in high-risk patients who are already compromised, like the elderly post-op patient receiving opioids or the patient with pre-existing COPD?
Well, the answer lies in their physiological differences. The post-op patient might have a high SpO2 but a rising EtCO2 because of opioid respiratory depression. That indicates a ventilation problem that's waiting to happen.
Sure.
The COPD patient may have a low baseline PO2, making any drop in their SpO2 significant. But utilizing EtCO2 provides a window into ventilation that SpO2 simply cannot offer. It allows you to catch that subtle shift before clinical failure occurs.
This foundational knowledge is your essential defense against missing those critical subtle changes. Thank you for joining us for this deep dive into foundational respiratory assessment.
Thank you.
We encourage you to apply this robust knowledge in every clinical setting you encounter.